Hello, everyone. This is Siddharth Damber from Chicago Arthritis and Regenerative Medicine. Welcome to our webinar today. So we're talking about regenerative medicine today. Before we begin, thank you everyone for joining. And if a few people in the audience, you can just let me know if you can see the screen and hear me clearly, I would appreciate it. Okay, great. Thank you very much. Great. So here's what we're discussing today in the webinar. You'll learn about the best available treatments for osteoarthritis, tendinitis that do not require surgery, including using your own cells, what is legitimate in the field of regenerative medicine, and how to choose the best physician and clinics for regenerative medicine. As we're going along, please enter any questions you may have, and from time to time, I will answer them. I try to answer most kind of frequently asked questions, but by all means, please enter your queries, and I'll get to them. And again, if you'd like to learn more about how we do things, you can go to chicagoarthritis.com. So the big question is, what would you do if your pain was controlled? How would your life improve? What activities would you restart? And what exercises would you restart? So a little bit about who I am. Again, my name is Siddharth Damber, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, specialist in image-guided musculoskeletal injections, in practice since 2008, involved in regenerative medicine since that time, 2008, and within the Regenix Network since 2012. The Regenix Network is the largest network of affiliated physicians working in the regenerative medicine field, sharing protocols, results, and best practices, which has been really a wealth of knowledge for me in my journey in this field. So in my personal journey into regenerative medicine, really started with my own shoulder. Used to play tennis when I was a teenager. And as I learned musculoskeletal ultrasound, I came to realize that I had an injury to my rotator cuff and didn't actually have pain at that time until I picked up tennis again in my 30s. And looking at the tendon and ligament pathology under ultrasound made me realize that there was a lot about the function of the joint and tendons that really I had not been appropriately kind of trained in until that time. And it made me start thinking about how do we do a better job of treating the sort of chronic injuries or even acute injuries that we all develop over time. That then led me to look for other treatment options rather than some of the traditional ones, which then led me into platelet-rich plasma, then eventually to bone marrow stem cells. So traditional care for musculoskeletal problems includes, and this includes for tendinitis and tendon tears, strains and sprains, arthritis and joint pains, back and neck pains. It's very much under the category of, can you mask the pain? You're just waiting for eventual surgery. And that's a terrible way to treat people because we don't really do that in anything else in medicine. For example, if you have diabetes, we don't wait for you to have your first heart attack before we start treating it. We actually try to treat that at the time of diagnosis to prevent those other problems. And for some reason, in musculoskeletal medicine, that frequently does not happen. So problems with traditional care, pain medications, they don't fix the problem. They can be helpful in terms of pain, but they have potential side effects. Not to mention opioid medications have a lot of potential side effects long-term. Traditional injections, including steroid injections, nerve blocks, radiofrequency ablation, again, they can give pain relief and can be appropriate from time to time, but they have problems. They have side effects if you use them too much or if you're overutilizing them. And so we need better, safer, lower risk, longer term options. So surgery has its role, but it's higher risk. It can accelerate the arthritis process when you start talking about common surgeries like knee arthroscopy in the setting of arthritis, to the point where the younger orthopedic surgeons do not do those kind of surgeries any longer because their data shows that it's not helpful. It leads to more instability, frequently, routine surgeries. And for those of us involved in regenerative medicine, our feeling is that the same way cardiac health went from a lot of cardiac surgery, open heart cardiac surgery, to now where most of it is managed through medications, diet, and needle-based procedures. And you're really only reserving the most severe things for surgery. And so for orthopedic surgery, that is the direction we are headed in as well. So in searching for better options, they need to be lower risk and avoid side effects. They should address the source of the problem, which is instability, inflammation, and metabolic issues. They should improve the actual cause of the problem, and they should actually give you longer-term improvement. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So if you think about how your body normally heals after an injury, take something as simple as, let's say, a cut on your finger. You first have platelets that come into that area, they stop the bleeding. They then release growth factors, which then stimulate your local stem cells, which then starts a coordinated process of healing. That includes inflammation, bringing in other cells, layering other tissue, and then eventually healing that damage. That works well when tissue has good blood supply. In tissue that does not have as robust blood supply, it doesn't tend to heal as well. And that includes tissue such as tendon, cartilage, ligaments, disc, labrum, and meniscus. And so regenerative medicine is taking those same cells, your own platelets or bone marrow stem cells, and then utilizing high level of X-ray and ultrasound guidance to inject the tissues that have been damaged and that are driving your problem. So why regenerative medicine? To begin with, it treats the source of the problem. Again, that is instability, that is inflammation. I'll talk more about that in a bit. Safer than surgery, of course, effective for most musculoskeletal conditions, and again, will eventually progressively become the dominant way that we're treating most orthopedic issues. So as we talked about, how does regenerative medicine work? Works by optimizing the damaged tissues that are causing your pain. We can also improve strength and stability by treating the supportive soft tissue structures around an area that's been damaged. That's called prolotherapy. I'll talk about that in a moment. This leads to reduction in chronic inflammation as well, which reduces pain. That stability also gives you better function. And we can also treat the neuromuscular issues as well, including nerves that may be pinched or irritated as well, that frequently drive pain. So it's a lot on this slide, but really, when you think about who should be treating your musculoskeletal issues, if you're looking for regenerative medicine treatment, they need to be really pretty high-level expert in a number of things. Number one, they should be musculoskeletal expert. What that means is if your physician is in one room treating somebody's knee, in the next room treating somebody's blood pressure, in the next room treating somebody's diabetes, the next room giving a Botox injection for wrinkles, that's not a musculoskeletal expert. That's someone who's kind of dabbling in a lot of different things. And medicine is one of those things where you want to be an expert in what you do. There's just too much to know, too much to get better at. You can't dabble in this. They should be a non-surgical musculoskeletal expert. There's a big difference in how surgeons are trained versus non-surgeons. And our surgeon colleagues are very good at the surgical part, but there's certain things that they don't get training in, including image guidance, that gives them a different perspective on how to do this. And if you come at this from a primarily surgical perspective, you'll see, it's that old adage that, if you're a hammer, everything looks like a nail. And you want to go to the non-surgical expert because this is not surgery. Number three is that you should use image guidance for all procedures. I have some older colleagues that feel that just by palpating the skin, they can understand where to really inject something. The problem with that is that some of these structures that we're trying to inject, the tissue damage may be 1 millimeter by 1 millimeter in size or even smaller. That is like fishing a needle from a haystack if you're trying to do this blindly just with palpation. And so until I have X-ray vision, I'm definitely using the tools that we have in the office, and that includes ultrasound and X-ray guidance, and your physician should have those skills. They need to understand how inflammation helps. Important, it's a subtle thing, but inflammation in the acute setting is generally helpful after an injury. Inflammation chronically is a problem. So if your physician is kind of routinely utilizing steroid injections for wear and tear arthritis and tendinitis, and you do not have an autoimmune issue, then they're really not understanding how inflammation is helpful in some cases. That makes a difference. So I would recommend that they have that understanding. They should understand the different types of biologic treatments that are used. There's several different ones out there. They need to understand what is appropriate given your pathology, your issue, and what is actually legally allowed in the United States. They should give you a very personalized treatment plan. It should not be every patient that comes in gets this same treatment plan. It should be bespoke, tailored to you. Again, it doesn't matter how busy your physician is. If it's a factory and they're just making one model, then you're getting a generic part. What you really want is something that is very tailored to you. They need to understand the concept of instability and prolotherapy. I'll talk about that a little bit more, but that's essential for these treatments. They should be transparent regarding results and your candidacy for treatment. It's not enough that you've shown up interested in treatment. It's that they should be able to tell you, are you a good, fair, or challenging candidate? And what does that mean in terms of percentage improvement? They should be willing to follow your results long term. If it's strictly a place that is doing procedures, injections, and you don't really ever see them again, it's not the right way to do this. And they should be able to guide you through this process. These treatments they're not new, but they are new to some practitioners, and they should be able to kind of talk you through what are the details here. So in terms of other basics, is this legal? Absolutely. There are definitely strict guidelines from the FDA. Those guidelines include things such as you need to use your own living cells, not somebody else's. You need to be able to take the cells, prep them, and then re-inject them the same day. And then you need to be injecting into orthopedic tissue. So if your physician is talking about giving these treatments via IV, that is not legal in the United States. If they're talking about treating conditions like multiple sclerosis or lung or cardiac issues, there may well be some evidence for that, but that is not legal in the United States. The vast majority of the evidence for these treatments is for orthopedic conditions and injecting your own cells into those areas. Another common question I get is, if I'm older, shouldn't I use someone else's cells? Absolutely not. For the vast majority of orthopedic conditions, there's excellent evidence of using your own living cells as effective. Understand that when you start using somebody else's cells, there are potential risks associated with that. You need to be careful. Your body is home to using your own cells, not somebody else's. So is there an age limit? For the most part, no. For the results that we have from knees, lower back, shoulders, elbows, ankles, and neck are not impacted by age. Hips, however, if you're over the age of 65, those are impacted by age. So again, your physician should be aware of these things. If they're not, then find someone who's a proper expert. What sort of doctor does these treatments? I talked about this, but they should be an MSK, musculoskeletal expert. They should be focused on non-surgical treatments, really a proper regenerative medicine expert, all those things that I discussed. Can these treatments help if you've already had surgery? Simple answer, yes. However, if you've had the joint replaced, then you can't really help out in terms of a joint that now has hardware. But if you have had, let's say, an arthroscopy, discectomy, and any of the kind of surgeries where you still have your own equipment, then yes, these can definitely help. My general recommendations for patients for orthopedic surgeries is try to keep your anatomy, try to avoid surgeries that are just cutting out tissue. Always consider a regenerative medicine treatment option if you've been recommended surgery to see if you can avoid going under the knife. Okay, somebody asking about blood flow. How does that impact stem cell efficacy? In tissues that don't have as robust blood flow. So what I mean is, a tendon is basically the end of the muscle where it inserts into the bone. That's typically an area that gets injured. The tendon is very tightly wound, very fibrous. It doesn't have the same kind of blood flow like the muscle does. So the muscle has tons of blood flow. So if you have an injury to the muscle, generally that heals on its own. You don't really need additional treatment unless it's severely torn. A tendon, on the other hand, even if it's mildly injured, tends not to heal very well on its own. Those cells are still very amenable and responsive to treatment. It's just that they tend not to heal on their own as well. And so by putting your own cells in, whether it's your own blood platelets, your own bone marrow stem cells, those cells still can thrive in that area and help to repair that kind of damaged tissue, in large part because those cells, they they're still amenable to treatment. The low blood flow state means that you don't get as much of your own cells into there. But if you put them in there, inject them into there in a planned manner, then you can still help out. So in terms of some of these key concepts with regenerative medicine, stability is very key. There's this concept of biotensegrity in architecture, which basically means that if you take individual units that are weak on their own, if you put them in close approximation and compression, you have a stronger overall unit. So that's tensegrity in architecture. In medicine or in science, that's called biotensegrity. Prolotherapy is the idea of injecting into those soft tissue supportive structures to strengthen the individual units to create an overall stronger unit. And the key is you have to treat all the layers and depth of treatment. You'll see a progressive strengthening over time, and you get a better, longer lasting result if you do that. So some examples. So this is an example of a older gentleman who's had chronic lower back pain. He's had some lumbar surgeries in the past. He's still having pain, something we very commonly see, unfortunately. So in his case, we treated every level that's driving this pain. That includes the epidural space where the nerves come out, the fasciculins that are arthritic, the ligaments that connect the bones together, the muscles that support that as well. By treating all those levels, in his case, he had some improvement with using his own platelets. We then ended up escalating to his bone marrow stem cells, which is a stronger treatment, which then gave him a much better response as well. Great example of where you're treating every level of pathology, you get a better response, and where using different cells makes a difference. Another good example of that would be if you're treating a knee. If you have knee arthritis, it's not adequate to just treat the knee joint. You have to treat the surrounding tissues, including the ligaments, the meniscus, as well as tendons, muscles, sometimes nerves, sometimes even bone. People will do better with that than if you're just treating the joint. Next key concept to understand is orthobiologic. These are the cells, the biologic cells and tissues that are injected into damaged orthopedic tissue. As I mentioned before, this is the normal healing process. Your platelets enter the area, they stimulate your local stem cells, which then starts that normal healing process. So the cells that we generally use, again, using your own cells, not somebody else's, that's where the safety evidence is. We talked about how platelets are key in this process. And really, I think probably the first line treatment to consider when you're talking about orthobiologics are platelets. You get these through a blood draw, concentrate to a high concentration of your own platelets, and that's what we re-inject. Utilizing focus inflammation, utilizing growth factors as well. There's different types of platelet preparation. On your image to the right, you'll see two different types of platelet preparations. You've got one that's colored red, that has a lot of red blood cells, that's more inflammatory. You want to avoid that in joints and tendons. It's okay to use that in muscles. And then you've got the picture on the left, which is a high concentration of platelets with the red blood cells removed. Less inflammatory, better for joints, better for tendons. You need to make sure that if your physician is treating you, they understand the difference between these two things. If they don't, they may not be giving you the best treatment. Understand that you can make versions of platelets where you're only taking the growth factors out, not the whole platelets. That's better for nerves. It's less inflammatory. You can adjust the concentration. Person who is, let's say, 75 years old with chronic knee arthritis needs probably a 14 to 20 times concentration of platelets, as opposed to, let's say, a 30-year-old who has a elbow tendinitis. You want to use maybe just a 7x concentration of platelets. So you vary the concentration. The way you do that is by using a lab-based open format to do that. A lot of my colleagues use very fixed systems that don't give them that kind of potential for flexibility. That's a problem. It doesn't give you the best kind of treatment option. So this is a nice example of using platelets. It's a 45-year-old man, cyclist, a recreational cyclist, essentially presented to me, referred by a sports medicine doctor with recurrent patellar tendinitis. The picture on the right is an example of that. He had failed conservative other treatment options. And at that point, that's when we kind of proceeded with platelet-rich plasma in his case. This ultrasound image on the right, this white structure here is the kneecap. On the far right, that is a tendon. As you get closer in, you start seeing some white kind of spurring. That is a sign of tendinopathy or tendon damage in the tissue, and that's what's causing his pain. So in his case, excuse me, let me just try to clear this. In his case, we ended up using his own blood platelets under ultrasound guidance. The picture on the right is a needle injecting into the tendon. We did that 2 treatments in his case, and he's back to full capacity and doing great. I saw him 3 years later, at which time now he'd injured his other leg, his hamstring tendon, and again treated that with PRP. And again, both cases was able to get back to full activity. Great example of how platelets are a very nice first-line option for treatment in a lot of issues, especially tendon issues, and how sometimes repeat treatment is necessary, and certainly treating other areas as needed makes a big difference as well. So you've probably heard a lot about stem cells. These are the main cells that drive tissue repair and recovery after an injury. Again, please use your own cells, not somebody else's. In the United States, bone marrow-derived stem cells are legal. In the United States, fat stem cells are not legal at this time because the enzyme you need to break up the tissue is considered unsafe by the FDA. You can use fat or adipose for structural support. We'll use that for some rotator cuff tears if we need a little bit more connective tissue, but do not use that as stem cell treatment just because there are some potential FDA issues. In the past, you probably heard more about amniotic or umbilical cord cells. You don't really hear too much about that now, and there's a reason for that. There's no living cells in that, just growth factors. And the FDA and the FTC have started to clamp down on that with practitioners that are using this. Medicare is sort of taking back money from physicians that they've paid where they've billed for this because these are just not considered kosher in this country. IV stem cells, no proven benefit for orthopedic conditions. You may hear about this being used in other countries. I would just be cautious. There's very little medical evidence. You need to make sure that the practitioner you're working with knows what they're doing. But again, for orthopedic conditions, no evidence that it's really helpful. Stick with what's proven, stick with what we know. In terms of stem cell treatment outcomes, frequent questions I get, yes, we can improve pain even in advanced cases. The one caveat to that is if you have advanced hip arthritis, but let's say advanced knee arthritis, advanced lower back arthritis, they'll still respond very well in terms of pain relief and functional improvement. So can we improve how your X-ray or MRI looks? I'll actually show you some examples of where we can do that. But if you have advanced arthritis, I think you should assume that right now we cannot do that. And yet we can still improve your pain and function. So the things that actually matter to most people, which is how is their daily function, how's their daily pain, as opposed to how does an X-ray image in the doctor's office look, we can still improve the pain and function. If you have a tendon tear, I'll show you some examples, but if the tear is less than 2 centimeters, we can actually get the image to look better. Same with ligament tears. If you've got swelling in an arthritic joint, we can improve that. If you have avascular necrosis at an early stage, we can improve that as well. I'll actually show an example of that. So can we treat bone-on-bone arthritis? This term bone-on-bone arthritis, I hear a lot of doctors using it. It's a very bogus term, unfortunately. And the reason why is the number of times you'll hear somebody say they've got bone-on-bone arthritis in their knee, and yet they can still flex their knee and extend it fully. That's not really bone-on-bone. So can we treat bone-on-bone arthritis? Yes, for the most part. Again, understand that arthritis is a biologic condition treatable with biologic treatments. In particular, if your range of motion and function are still intact, good outcomes are definitely possible. Caveats. Number 1, advanced hip osteoarthritis, very challenging to treat. That is the one exception where bone-on-bone really makes a difference. Expectations, again, I would say focus on pain and functional improvement. Improving imaging is unlikely if you've got more advanced arthritis. So this is a nice example of where we can treat tendons and ligaments. This is a knee ACL case. This is I saw him a few years ago. It's a 28-year-old man who he's a butcher, recreational volleyball player, injured his ACL. This is several years ago, and I saw him a few months after that, a couple months after that. We ended up doing bone marrow aspirate concentrate stem cells at the 3-month mark after treatment. No pain. He's back in dynamic activity. I'll show you what his images look, which is really quite remarkable. And he's now several years out and still doing great. The X-ray image on the right. So I'll just kind of mark some spots. First one, that's the kneecap. This is the femur or the thigh bone. And at the bottom, it's the shin bone or the tibia. So this structure here is the needle that's kind of going into the knee. You can really only inject the ACL under high-level X-ray guidance. And what you see lighting up here is the ACL. So how do we know we're injecting the right tissue? It's with image guidance, and it's because we can actually see the structure as we're injecting it. And so here is what his imaging looks like a few months after treatment. And this is pretty exciting because normally we're really focused on functional improvements. So the MRI on the left, again, kneecap, thigh bone, shin bone. This is his ACL right in the middle. At the bottom, it looks intact. As you go higher up, it gets very murky, very distended, disorganized. The radiologist has read this as a likely full thickness tear. The image on the right now, here you have the ACL again. This is 3 months after MRI images. This is essentially a normal looking ACL now after treatment. And that's how the radiologist has read this. In addition, so not only great functional improvement in terms of activity and pain relief, but also really quite remarkable imaging improvement as well, which is pretty exciting. An example of a rotator cuff injury. So this is a gentleman, a patient of mine. He's a 50-some-year-old man, general contractor doing a lot of overhead activity. Came to me originally with a shoulder injury in his dominant arm. So the ultrasound image on the left, the two images on the left are ultrasound images of the rotator cuff. So the white structure here is the bone. This is a little bit of snippet of the tendon, and this gap right here, this hole right here, that is a tendon tear. Same thing down here. That's a full thickness tear. That's pretty significant. On the right side, you see him 3 months after treatment, no pain with activity or sleep. This is an ultrasound image where you used to see just a big black hole of a tear. Now you have tissue that is regrown and filled in there. Again, doing great several years after treatment and just great imaging results as well. It's just very exciting. Somebody just asked, but will be receiving the slides? You won't be getting the slide, but you'll be able to see a review of the video. You'll get a link for that. It's on the YouTube page. You can watch that anytime you want. You can have to share that as well. Somebody asking about platelet first treat versus adding pluripotent stem cell. You are not exactly sure what's being asked there, but normally when we are injecting, so there are some conditions where we will only use platelets. For things that are mild to moderate. For things that are moderate to more advanced, we'll generally end up using bone marrow stem cells. When we utilize stem cells, we'll end up combining platelets as well. And the reason why is because your platelet growth factors help to stimulate your stem cells. And so you kind of get an added boost as you're doing that. Somebody asked about a tendon tear that's more than 2 centimeters. Would you recommend treatment? What is percent decrease in effectiveness? Yeah, so it is better if your tendon or ligament is torn less than 2 centimeters. For a tendon, the different types of tendon tears. So I'll just kind of show with my hands here. A normal tendon is fully intact. A fully torn tendon is sort of fully pulled apart. Partial tear, you may have half of it kind of torn. But then there are also full tears where they're still closely approximated. Those tears that are fully apart need surgery. Those tears that are still closely approximated, even if there's a full tear, can still be treated non-surgically. Absolutely, we can still do that. Again, a lot of it depends on the person, how long have they had their injury, what other problems do they have, but yeah, those can still be treated. Somebody asking about ankle and foot cases. Yep, we can definitely treat that. I'll show you an example of that as well in a moment. So interventional orthopedics. So this is the idea of utilizing image guidance to treat orthopedic injuries. So we'll show a few pictures here. So to begin with, again, as I mentioned before, um, none of us have X-ray vision, so we need to use image guidance for this. So the picture on the left is an ultrasound injecting into the shoulder rotator cuff, bone there, tendon here, needle there. This is a very small tear right here. That small little black gap right there. Very, very small. This is a zoomed in picture, right? So that is less than 1 millimeter by 1 millimeter. And so to hit that, you need to use very high level ultrasound guidance. Picture on the right, this is again the shoulder. This is a humeral head. That's the glenoid and the ball and socket joint. That's the needle. There's two things to notice. Number one, you see a little kind of linear line right here, or curvilinear line here. That is a little bit of contrast injected into the joint to confirm we're actually in the joint. When you're injecting cells, it cannot be just close to the target. You have to be directly. You have to be, at that less than sub-millimeter level. You have to do that to really get cells in there. Otherwise, you don't get an effect. The other kind of interesting structure here is this triangular structure. That is the labrum. That's the superior labrum. To hit that structure, you really can only do this under high-level X-ray guidance. And so exciting because here we are able to treat not only his shoulder arthritis, but also his labral tear as well. And again, someone who did well with treatment. So these are examples I showed before. The picture on the left, that's injecting into the patellar tendon. That was PRP treatment. And the picture on the right is injecting into the ACL with this person's own bone marrow stem cells. Again, utilizing high-level image guidance to make sure you're hitting the right structures is essential. Somebody asked about foot ankle issues. This is a nice case. This is a 40-some-year-old man with history of, he's a chef. And so he's literally standing on his feet for like 12 plus hours a day. And so as you can imagine, in this kind of person, he's developed a couple of problems in his ankle. For starters, he developed arthritis in the ankle. For another, this white signal inside the bone, this is called avascular necrosis. What that means is that the blood supply in the bone is dying off, and this basically killing off the bone, which will eventually then damage the cartilage as well. So in his case, we ended up injecting his own bone marrow stem cells into the joint, the ligaments, and into the bone. 3 months later, symptomatically doing great. The fluid in the joint is gone. And the picture on the right, you can now see what was previously swollen and kind of dying bone has been completely reversed. And so he's a few years out from treatment and doing really well. And just a great example of where, in the right cases, you can get not only a great degree of pain relief and functional improvement, but also get really great image improvement as well. Regenerative medicine treatments offer safe and effective solutions for your pain. Again, if you want to learn more about how we do things, you can go to chicagoarthritis.com. Common questions I get: is this too good to be true? So, there's evidence from Philip Hernigue. He's a French surgeon that goes back to the 1990s, mid-1990s. He literally has cases where he does shoulder surgery on one side and other side of the shoulder surgery and adds in bone marrow stem cells and compares the results. He has cases where he does knee replacement on one side and then bone marrow stem cells on the other, compares the results. What he finds is that in shoulders, he finds that his patients that had a rotator cuff repair, when they added in the bone marrow, it prevented re-tears more likely than if he didn't do that. And his patients that had knee arthritis, the patients who did knee replacement surgery versus the ones who did bone marrow, an equivalent result as well between the two knees, same patients. Regenerative has data that goes back to 2005. I have colleagues who feel like this is a very new field. It's new, but it's rapidly developing. It's not that, right? I've been personally doing this since 2008. Again, colleagues have been doing this even longer than that. There's definitely right and wrong ways to do this. I used to have colleagues who 10 years ago, even 5 years ago, would say they didn't believe in these kind of treatments. And now, as they progressively see more and more data, they'll say, well, I'm not sure if it helps, but I don't think it hurts. I think it's interesting. sometimes if you're not like in the midst of things, you don't realize how far things have progressed. But these treatments have been around for a while and they've been refined over time. And there's right and wrong ways to do this. You need to have your expectations grounded in reality and evidence-based medicine, but these are not too good to be true. How long do results last? Again, Regenix and Dr. Hernigue have data that goes for a while, right? For over 20 years now. What I tell patients is always think conservatively if you have a chronic condition. Example, if you've had knee arthritis for 30 years, expect that you'll need a repeat treatment at some point. That might be if you had, let's say, a bone marrow stem cell treatment on day one, that might be you get a repeat bone marrow treatment 5, 7 years later. It could mean that you get a platelet booster shot in 2 years. It depends on the person and how you're doing. But I think if you think conservatively and understand that these treatments will optimize your joint, optimize your health, and that a repeat treatment down the line is actually synergistic and helpful, that's a healthy way to think about this. Regenix has some data where repeating treatment, first treatment got people to one level. After a few years, if they had the repeat treatment, they're now building off that higher level and stair-stepping to an even better improvement later on. Best way to maintain results after treatment. Improve your biomechanics, work with physical therapy, do the right exercises, use the appropriate joint supplements. Repeat treatment is definitely additive. If you repeat that, maintain ideal body weight as much as possible. Reduce stress on the lower back and the legs if you can reduce weight to an ideal body weight level. Improve your metabolic health and inflammation. So key. Metabolic health and inflammation are such an important part of inflammation in the joints as well, to the point where we now have our own physician-assisted weight loss program to help patients with that as well, because we see the value in not only treating weight loss, but in terms of how that helps with our patients with arthritis and overall metabolic issues as well and inflammation. So key part of this, I would definitely look into that also. Cost, everyone needs to know about this. Not routinely covered by insurance. There are some exceptions to that. TRICARE is the military government insurance for active duty military personnel. We'll cover PRP for knees and for knee arthritis and elbow tendinitis. Their Regenix corporate has now, I think, several hundred companies around the country that are self-insured that have added this to their benefits plan, including some larger companies now that will actually treat this as like a normal insurance product. If you're paying out of pocket, which is still the vast majority of people in the country, cost estimates are listed here. Would expect that kind of anywhere you go in this country. I think the keys to determine value are really as follows. Is your physician and the clinic, are they regenerative medicine experts, or are they just dabbling? Are you receiving a real stem cell treatment or something like a amniotic umbilical cord treatment that's been mislabeled? And understand that these can be done in the office so you can avoid hospital and surgery center facility fees as well. Talk about what makes a regenerative medicine expert, right? It's really all these things, do it right. And if your physician is doing it correctly, then you can expect to have most likely a good and consistent result. So a little bit about how we work here at Chicago Arthritis and Regenerative Medicine. Focus on non-surgical treatment for your arthritis, tendinitis, injuries, and back pain. Start by evaluating for inflammation, instability, asymmetry, neuromuscular issues, correcting with low-risk interventions. If not working, then escalating to stronger treatments, including regenerative medicine treatments. Focusing on the highest quality products from your own body, plan that is specifically tailored for your condition, and utilizing the highest level of image guidance to deliver those cells into the place that they need to go. How to get evaluated. So in the chat section, you'll see a few different ways to contact us, including by phone, email. We also have our direct scheduling link where you can schedule this directly through our EMR. Somebody asked, let's look at a couple of these other questions. Somebody asking about, so the avascular necrosis treatment for the ankle, that was utilizing bone marrow stem cells and PRP. That was a one-time treatment, still doing great. We caught him at the right time. Another question, someone mentioning they're in their 70s, diagnosed with severe arthritis and bone spur in the left hip, not in much pain, am very functional and mobile. what would the process look like to determine if you're a candidate for blood platelet therapy? Really, it's an evaluation, right? Proper medical evaluation, namely, um, um, talking to you, examining you if you're local, looking at your imaging, and then determining, are you an appropriate candidate? What other medical issues do you have going on? What else? What are your goals in treatment? And then deciding what's the right treatment to use, whether it's blood platelets or bone marrow stem cells. Right. Somebody else asking about cost of evaluation. If you've got insurance, your visits, follow up, imaging, any kind of bracing if that's ever needed, physical therapy, all that is covered through insurance. If it's really just the procedures that are out of pocket at this time. If you're someone who's on a network or or um, uh, or just your cash pay, then for evaluation, please just check in with the office and they can give you what is our cost for evaluation and follow-up visits as well. Wonderful. Well, we're coming to, I think, the end of our time here. I appreciate everybody's time. And for any specific questions about which insurances we accept, please just contact the office. They can go through that directly with you. A lot of these depend on which insurance you have and which sub-insurance of the insurance you have, and all those kind of details. So please just check with the office directly, and they can help you out with all those details. Okay, somebody else asking, okay, how does parathyroid hormone and osteoarthritis relate? Yeah, so if you have hyperparathyroidism, you'll have a high level of calcium in the blood leaching out of the bone, which then makes the bones weaker. Sometimes that can also lead to a condition called pseudogout, where you have calcium crystals that end up in the joints that can then cause inflammation, then eventually wear and tear arthritis. So depends on how severe the parathyroid hormone issue is, but it can cause joint issues. Great. Well, if no other questions, thank you everyone for your time. You'll get, okay, one last question. Someone asking about the Cayman Islands. The Cayman Islands, different process. So Cayman Islands are outside the United States. There, they are able to do what's called cultured stem cells, where they take your cells from a bone marrow aspiration, then grow it out, and then re-inject it. In the United States, we are not allowed to grow it out like that. We have to do everything on the same day. So indications for utilizing stem cell treatments via the cultured process would be, if you had, let's say hip, kind of like bad hip arthritis is a good indication. Most of our patients, let's say for knees, shoulders, backs, other kinds of areas as well, do fine with just using the same day stem cell treatment option. There's the rare person that needs to go get the full kind of cultured process. I think if you want to learn more about that, Regenerative can give you more information, details at the same time. If you need to treat multiple areas, let's say 2 rotator cuffs, that is still treatable by using your own cells here in this country without having to go to the Caymans. If you're treating like 6, 7, 8 places, then it may make sense to go the cultured route. Understand that there's more involved in that, right? You're going to a different place, getting your cells harvested, coming back six weeks later. Obviously, additional expense with that as well. So somebody asking about cervical spine instability. So DMX is a great way, digital motion X-ray is a great way of evaluating for instability in the spine. For cervical spine issues, I refer that to other colleagues in the network to help out with that. That's not an area that I'm focused on. Another question asking about how do we treat arthritis and bone spurs in the lower back? Bone spurs. So why does your body develop bone spurs? So your body is very highly attuned to instability. If a ligament has been damaged and cannot be healed on its own, and there's instability there, your body will put calcification into that area. And that's what a bone spur is. Understand that the bone spurs are not causing pain. All right. The bone spurs are just a sign that you have instability there. And so the the um, the right way to treat, let's say, lower back arthritis is that you want to treat every level where there's problems. And that includes treating the epidural space where the nerves come out that are pinched. You want to treat the ligaments that are unstable. You want to treat the facet joints that are arthritic. You want to treat the muscles that have been weakened over time and atrophied over time. You treat every level. Generally, we're using blood platelets for that. But that's the key. You want to treat every level of the problem, and addressing really where the instability and inflammation is. Okay, great. Yeah, you definitely can use PRP for treating lower back issues, safer than doing steroid injections again and again. Asking about stenosis. Yep. If you understand why somebody has, let's say, lumbar stenosis, it's because of weakness in a ligament that's then leading to the overall structure collapsing a little bit. So the key is treat the ligament that's weak to help improve the overall stability of the structure. Great questions, guys. Um, I am at the end of my time today, but thank you everyone for your questions and your time. I look forward. You're welcome. Appreciate everybody's time. And if we can be of additional assistance or questions or helping you out with your own issues, please let us know. Until we connect again, hope everyone has a good day and live well. Bye-bye.